the bands, I went and put the device. So the parietal hypertrophied bands can cause problem at times.
And sometimes they can also cause sub-PS after USD. Okay, General RVOT.
I recorded a very good echo in that, and then, you know, we went in between the bands and we could do it.
Okay, so I think we'll start on time.
Yes.
Good evening, friends, and welcome to the second day of the second edition of Interventions in Congenital Heart Disease. Learn from the masters. And today's guest is Dr. Chetan Mehta from Birmingham, UK. And as you know, they have probably one of the largest experiences of RVOT stenting in the world. So without much ado, I will request Chetan to give his presentation on palliative right ventricular outflow tract stenting, extending indications. Over to you, Chetan. You will have to... Oh, unmute Chetan. No, I'm sorry. Yeah. Nageshwar is here. Nageshwar, you are the moderator for this, and it's over to you. I'm so sorry.
Yeah, absolutely fine. Good evening and good morning, Chetan. We are happy to have you today here. I think Dr. Bharat already introduced you. We are just waiting for you to speak on palliative RVOT stenting. Even from Indian perspective, we reviewed a lot of literature coming from your center. Yeah. So I request you to go ahead with your talk, and then we can take some questions at the end of it.
Yeah, it's a pleasure to be joining all of you guys. It's a great platform. I think the most important thing was, I think somebody's microphone is still on. It's giving a lot of background noise. I think I just wanted to let you know, even Oliver Sampa is probably going to join this from where he is. So he might be already on Zoom. So without wasting much time, I basically wanted, when I was asked last week by Usri and Satya whether I gave some talk, and I felt that we have done quite a few RVOT stenting talks, but we could probably try and see whether we can talk about extending the indications. And that's why I kind of modified the talk rather than to a conventional RVOT stenting talk. So disclosures for this talk, financial or none. Domestic disclosure is I'm currently at home looking after two girls, 13 and 7. They're usually well behaved, but the 7-year-old might keep coming to me asking me questions like whether she can use an iPad or whether she can watch TV or whether she can play with whatever game she has got. And the professional disclosure is I am working from home today, so my phone might still go off and I might have to answer it. As you saw just now, it went off while I was on talking to you guys. So essentially, I think we know about all this. The incidence of Tetralogy of Fallot is about 3 per 10,000 live births, and it forms 7 to 10% of the usual congenital heart disease load. They usually get into trouble, if at all, during early infancy, and some of them who do go into trouble are immediately once the duct gets shut in the immediate neonatal period. 20% of children will have Digeot syndrome who have Tetralogy of Fallot, but the presentation may depend upon how much degree of subvalvular and valvular stenosis, and obviously some supravalvular stenosis as well. I already mentioned that in some babies, they do get into trouble as soon as the duct starts getting closed. I think as majority of people know that we have been doing RVOT stenting since 2005, initially in a very selective subgroup of patients, but now it's become kind of our standard practice. Wherever the surgeons say that we cannot repair the Fallots, we would go for RVOT stenting. I would like to emphasize that still 75% of the cases would go for a primary repair in our department. And the principle of the procedure is basically to address the anterior deviation of the outlet septum, which we see in the Tetralogy of Fallot. You want to try and see where they can shift the septum posteriorly. And by doing that, you allow more deoxygenated blood flow to get into the pulmonary arteries. If possible, you can avoid stenting across the pulmonary valve. And I think that is still a point of debate. But if we found in our practice that if we find the pulmonary valve annulus is good size, then it's probably worth sparing the pulmonary valve not to cross the stent across. We've already demonstrated in this paper the superiority of RVOT stenting compared to a BT shunt in the pulmonary artery growth. and I don't want to dwell on that area at the moment, because I think the main purpose of this discussion was addressing the variant of Tetralogy of Fallot, whether they could be considered for RVOT stenting. The two areas which I would concentrate today is, one is AVSD Fallots, and the second one is Tetralogy of Fallot with major aortopulmonary collaterals. Now, double outlet right ventricles do sometimes end up in the similar spectrum as Fallots, but sometimes you do have some cases where DORV, but there is not much of sub-PS. But if there is sub-PS and there is significant desaturation and primary repair is not possible, potentially can be considered for RVOT stenting. Isomerism, usually the right atrial isomerism where they have unbalanced AVSD, they tend to have pulmonary atresia, but some of the cases tend to have pulmonary stenosis and subpulmonary stenosis, and those cases potentially can be considered for RVOT stenting. And very rarely in tricuspid atresia, if you have got a small RV with subpulmonary stenosis. So the technique, I think, with great pleasure, I want to mention Oliver Stumper, who basically has standardized and simplifies this technique. So everybody is following this technique more or less throughout the world. And essentially, if it's a neonate, we tend to prefer a coronary stent, which is usually delivered over coronary wire through a 4 French flexor sheath or a 6 French guide cath. If it's an infant, then, and if you need the palliation to be for a longer time, then you can use a Cook formula stent, which can get from 6 millimeter up to 10 millimeters, and you can dilate them up as and when you need them to be dilated, because those children are going to grow, and the diameter of the stent might need to be restretched if the child is still not ready for a complete repair. And as I mentioned previously, you can cross the valve if the pulmonary valve annulus is small, and if there's supravalvular pulmonary stenosis. But if the valve annulus is good, and if it can be spared, it potentially might help you with the growth of the pulmonary valve. So I think this is just a picture concentrating on the morphology of the atrioventricular septal defect and Fallots-Tetralogy. And I think the picture on the left or the right of the screen essentially shows the pulmonary valve and the muscle of muscular outlet septum, which is kind of deviated. And the mirror image of that is on the echocardiogram, which is showing you the AV valve and the infundibulum below the PA with the outlet septum, which is deviated. And essentially, this is what we have to keep in mind when we're thinking about doing palliation of RVOT stent in these patients, the anatomy. Now, why do we have to consider this as an option? I don't want you all guys to start reading this paper, but essentially it's a surgical paper. And the reason I told it is because number one, it's from Boston. It's a good number of cases. It's a 61 patients over a period of 29 years who underwent repair with atrioventricular septal defect with Tetralogy of Fallot. The interesting thing is the primary repair was done in 36 patients, and 25 patients required initial palliation. I think we as interventional cardiologists need to target those 25 patients, because here, those 25 patients underwent a BT shunt to augment pulmonary blood flow. And in today's day and age, potentially those 25 patients could be palliated with the RVOT stent. Again, another surgical paper, which is combined from Germany and France, essentially looking at the same thing. And they also had more or less 50% secondary repair in terms of requiring palliation with the BT shunt. And their outcome was not much different, whether it was a primary repair or whether it was secondary repair. But again, targeting those 50% of patients instead of going for surgical BT shunt, where you would expect volume loading and potential AV valve regurgitation in a physiology of AVSD. So I think sometimes picture speaks louder than words, and I think that's why I just showed a case of AVSD. And this is our conventional view. I think this was a patient of mine with who was about 3.4 kilograms, AVSD with Tetralogy of Fallot, and had some chromosomal abnormality, and was having significant desaturation spells. And Oliver and I did this case together because this was quite a few early on cases of AVSD Fallots. So this is angiogram done in the RAO 30 view, showing you the right AV valve and the RV cavity with the outflow tract and the infundibulum and the pulmonary valve. And I can imagine, if you remember the specimen which I showed you earlier, it shows you pretty much the same anatomy over there. And that's lateral of the same thing. Just to say the morphology, the difference that we found in the AVSD cases that we've done is the infundibulum and outflow tract is more horizontal compared to what we see in the standard tetralogy of Fallot, which is more vertical or slightly maybe obtuse. And where if you don't see the bifurcation very well, this is a cranial view, cranial 35 AP, showing the bifurcation of PA and how the actually infundibulum meets up with the pulmonary valve. So this is again another angiogram with the catheter just sitting underneath the pulmonary valve, showing you how small and tight the pulmonary valve is, and there's some degree of stenosis in the supravalvular area as well. So as per our usual plan, normally once we have crossed it, we put a coronary wire and then use a coronary balloon to balloon the pulmonary valves. So this is what is being done at the moment. And with this technique, what also helps is to get that sheet across into the pulmonary, across the pulmonary valve. So when you're deflating this balloon, you basically use it as an anchor to try and get the sheet into the pulmonary artery. Once the sheet is in the pulmonary artery, you can then deploy the stent. And I think these are check angiograms performed before you deploy the stent, both in the RAO and the straight lateral view. And once you are happy with the position, you deploy the stent. And in this child, I think the initial stent was the coronary stent. I know from memory, because she's my patient, that we had to put another stent into her because she had significant other problems that did not go for repair immediately. So she went for complete repair at about almost 2 years of age, and the surgeons preferred to put a RV2 PA conduit in her, and she's done very well. The number of cases, I think I'm just sharing the experience between ourselves and Dublin. Dublin is another center which does a fair amount of RVOT stents, and I'm thankful to Damien Kenny, who basically has agreed to publish the data along with us with Birmingham Children's Hospital, and it is currently in the process of finalizing the paper. So between the two centers, we have implanted RVOT stents in both balanced and unbalanced AVSD with Tetralogy of Fallot in 26 patients. And 50% of those patients with Down syndrome, 1 patient had Noonan syndrome. There were associated co-abnormalities in 40% of patients of duodenal atresia, malrotation, laryngomalacia, and some prematurity. And another 40% had hypoplastic branch pulmonary arteries. So the result, basically the median weight at which the stents were implanted were about 3.7 kilograms. We found the improvement in saturation from a median of 72% to 90%. The Z score for the left pulmonary artery diameter increased from -1.2 to 0.5, and same for the RPA from -1.29 to -0.18. 9 patients required RVOT restenting because of progressive desaturations, or they have outgrown the first stent that was put in place and they were still not ready for complete repair. And 5 patients underwent balloon dilatation of the previously implanted stent. 1 patient unfortunately died after RVOT stenting, and 1 patient required modified BET shunt. And to date, 19 patients have undergone repair. Up to 15 were biventricular repair. The other patients would have gone for CP shunt as a stage 2 palliation for univentricular circulation, especially the isomeric patients. The another morphology which I think I would like to extend the indications to is Fallots with aorta pulmonary collaterals. I think again this is a very rare condition. A lot of times we do see pulmonary atresia Fallots type with aorta pulmonary collaterals, and the management of the patient is depending upon the how much blood supply to the lungs is provided by the native pulmonary arteries and how much supply is from the MAPCAS. And our unit has been a strong advocate of cardiac catheterization quite early on to delineate the pulmonary artery supply as well as finding out the native pulmonary arteries with pulmonary vein wedge injections. However, we found some cases of Fallots where there is forward flow and there are MAPCAs. And though it is very rare, I think it's one indication where probably RVOT stent should be considered if the emphasis is on growing the native pulmonary arteries. So in our unit, basically, we have a fair amount of pulmonary arteries that VSD MAPCA work, and the same analogy we apply for the one with forward flow. This RVOT stenting has already been demonstrated by the paper from Toronto, where they had initially demonstrated their RVOT stenting experience. But the whole group had 13 patients which had Fallots with pulmonary artery, with small pulmonary arteries and some collaterals, and they had some very good results. So again, I'll show you a case which I think is a patient who presented to us with severe deoxygenation and was referred to us for ECMO actually, because they thought there was some pulmonary issue. And when the patient came to us, the diagnosis was made to be pulmonary atresia with no forward flow seen at the time initially on the echocardiogram, and there were a lump of collaterals seen. I think Oliver did this case, and essentially I'm just going to show his angiogram. The first initial angiogram which was done on day 6 or day 7 when the patient was a lot more stable, and you can see it's a right aortic arch and the catheter is sitting in the almost like an infundibulum, but you don't see much of forward flow at that point. And that's the lateral of it. You can see almost something like a valve plate, and but not much of dye going across. But fortunately for our luck, this catheter went through quite easily with the help of a wire, and you can see what the native PAs are like. And you can see there's a good amount of blood supply seen to the right lower lobe, right middle lobe, and more or less the whole of left lung on that. I think a more robust angiogram shows also your collateral, which is coming from the filling up of another collateral, which is coming from the right innominate artery, which is also being filled up when you do the forward injection. So I think what Oliver did at that point was he ballooned the valve plate initially and then put a stent in there, because the intention was to, because the pulmonary artery, native pulmonary artery had a good supply to the right, middle and lower lobe, as well as a good left lung. We wanted to grow those lung arteries. And then you see, this is the result immediately after the stent was implanted. And at that point in time, we did look at the MAPCAs, but it was not important, because it was important to kind of stabilize the child and see how the native pulmonary arteries grow. And when it comes to kind of doing the complete repair, we could think about blocking some of those MAPCAs if there is dual blood supply. So this child, unfortunately, turned out to have syndromic abnormality, had some major airway issues, has been on a long-term ventilation, and but still the saturations were maintained quite well with the initial stent until recently. And you can see the date of the catheter is 24th of March 2020, when Oliver actually took him again to the cath lab because there was significant desaturation. And these are the MAPCAs which I've just shown as a still, which is supplying to the right lower lobe as well as some of the areas of the left lung. And essentially some of these MAPCAs could be blocked off once we know that the blood supply to his native pulmonary arteries are good. And you can see the angiograms on the right of your screen basically showing forward flow through the stent, which has been stretched again by Oliver, and there is good flow into the right lower lobe, middle lobe, and the left lung. So at this point in time, this child is still quite not suitable for a complete repair. So we were going to let him continue growing till basically at a point we can do a complete repair. So far we have done in this kind of morphology 9 patients with Tetralogy of Fallot with forward flow with collaterals, and the weight at which this patient, median one was 4.3 kilogram, with the youngest patient having weight of 3.6 kilogram, and we found saturations improved immediately after putting the stent in. And some of these patients who have a lot of comorbidities, you might need to do repeated dilatations before they will be suitable for a complete repair. Some of these patients, when they're taken to the cath lab in the immediate neonatal period, could be on Prostin to maintain the duct, but if there's no duct, then basically the Prostin will be stopped after the cardiac catheter. So we found that the patients who've had more than one cardiac catheter, their Z scores the pulmonary artery is definitely improved from -3 to -1.4. Saturations increased by almost 10%. There was one procedural death and one lead death. Further intervention is something which will require ongoing because of the stents don't grow with the patient. You have to keep stretching them, and sometimes you have to dilate some of the branch pulmonary arteries, and sometimes you have to occlude the macas where there is dual blood supply. 3 patients of those have undergone complete repair, 2 with RVT conduit and 1 with a transannular patch, and 4 remain still palliated. I wanted to add certain rare indications, but I think with a word of caution. The isomeric hearts is something which we have done, I think, about 6 patients so far, especially the right atrial isomerism with subpulmonary stenosis. And these are the patients where if you have an interrupted IVC, you might have to do it from the neck. It gives you a nice good curve. And potentially the subpulmonary stenosis can be stented open with the RVOT stent, and the palliation can go on for 4 to 6 months. And then after that, the surgeons can either repair the pulmonary veins and do a CT shunt at the same time. I just wanted to mention tricuspid atresia because I'm just very wary of this condition. With tricuspid atresia, where you have a VSD and a small right ventricle, if there is subpulmonary stenosis, RVOT stent is feasible, but the pathway that you're using to do the RVOT stent is from across the PFO coming across to the left ventricle and then through the VSD into the RVOT, and the risk of heart block is quite significant. Oliver has done one patient. This was almost in 2010, almost 10 years ago, and essentially the procedure was successful, and the patient had AV block at the time of procedure, but recovered completely, did not require a pacemaker. But majority of this patient actually run into problem because of the VSD becoming restrictive rather than actually having a sub-PS. So it's very important to delineate whether is it because of the restrictive nature of the VSD or is it truly sub-PS. And the risk of heart block is always there when you're trying to do a procedure through a VSD. So in conclusion, palliative RVOT stenting is established already in Fallots, and I think is now embedded in everybody's practice more or less all around the world. This procedure should be and can be considered for longer palliation in complex heart, especially where you have reduced pulmonary blood flow. Things like AVSD Fallots, with Fallots with collaterals, and potentially even either isomeric hearts. It is more physiological compared to BT shunt, especially in conditions like AVSD Fallots, because with BT shunt, you increase volume loading of the ventricle and potentially cause more AV valve regurgitation, which you don't see with the RVOT stenting. I would like to acknowledge Oliver, who has predominantly done majority of his work on this RVOT stenting and the extended indications. Special thanks to Damien Kenny from Dublin, who kindly shared the data about the AVSD fellows from Dublin. Ryan, who's one of our registrars and interventional fellow who's collected the data at Birmingham, and Riz Rahman, who's now a consultant in Leicester, who has done a lot of work on the RVT stenting, collecting data and presenting that information. And the team at Birmingham Children's Hospital, and to you guys for allowing me to the presentation and listen to me patiently. Thank you.
Thank you very much, Chetan. It's a really wonderful and lucid presentation, and you shared a lot of your experience from your center. As usual, there are so many questions. To summarize, there are close to some 20 questions are there. I will just put 1 or 2 interesting questions first. How early you define the surgery in your center after a stent? So that's what most of the people, they would like to know actually. How early you would like to do the surgery?
So I think if the conventional tetralogy of Fallot, then usually if patient did not have any palliation, majority of them will go between 9 months to 1 year of age. However, if you put a RVOT stent, the whole purpose of doing RVOT stent was because either the PAs were small or the child had other coexisting morbidities. So after you put a stent, the patient's saturations are holding up fine, we would allow the child to grow as much as possible. If the saturation then start dropping, then we would want to image the PAs either by repeating a cardiac catheter or a CT scan. As an interventional cardiologist, majority of us would prefer to image with a cardiac catheter because the PAs are not good enough. Then we would then consider stretching the previously implanted stent. However, if the PAs are good enough, we could then share it with the surgeons and say we are happy that this patient can be taken up for surgery. And
our
majority of the time the
experience
surgeons
is,
would agree with that.
yeah, I agree with that. Our experience in our country is a little bit different. Once you put the stent, 3 to 6 months of age, if you try to re-evaluate the child, where PA adequacy and baby's weight will be adequate for surgery. What is happening is our center experience, the more you wait, like more than 6 months, again PA growth is going to be stopped there, or surgeon is finding difficult to retrieve the stent. So welcome Dr. Oliver Stumper. This is Rao from Hyderabad, India. So wonderful presentation by your colleague, and we saw the data from your center. We had a question and he answered very well. But I will take a question from Bharat sir, Dr. Bharat, and probably if Chetan allows me, I'll ask Oliver to give a comment on this. Is it okay, Chetan?
Absolutely. Absolutely.
The one question from Dr. Bharat is there over circulation after RVOT stenting in these cases? Number one. 2 question for me, do you regularly put stent across the annulus in case of a smaller size annulus? So we would like to know from you these 2 answers.
Satya, can you unmute Dr. Stumper, please?
Can I repeat the question, or you got the question already? We can't hear you at this point of time.
Sir, you already unmuted.
Okay. Oliver, can you hear us?
Chetan, we can't hear him. You can take the question. Because since he logged in that way, to respect his seniority, I asked them.
So I think first thing about the valve annulus you talked about, yeah? The first question was valve annulus.
The question is over circulation, Dr. Bharat asked actually.
Yeah, so I think we have seen over circulation to the extent that sometimes they can have one-sided lung completely going into kind of reactive area. So reactive pulmonary edema kind of thing as well. So those patients, we do end up sometime ventilating them for a bit long rather than extubating them onto the table. They would take them to ICU and give them diuretics to make sure that the body gets used to the increase in pulmonary blood flow, and then extubate them once we are happy that the over circulation is under control. There are a small proportion of children who we find that they are over circulating. We would keep them on diuretics. And once we know that their work of breathing is comfortable, the pulmonary circulation overflow is not too bad, then we would be in the diuretics. But a small proportion would end up on diuretics.
If you stent, would you like to put across the pulmonary annulus stent, still you salvage the annulus?
No, if it's small and it's not worth salvaging, we would go across the stent because, sorry, across the valve. You put the stent across the valve because it allows you actually to give more, what do you call, stability to the stent. That's number one. Number two is if there is, usually there is some supravalvular stenosis as well, and that area gets covered with the stent as well.
Okay. So, and some more questions like, why do you want to re-stent it rather than that you can redilate the stent? And also, did you come across any case where you wanted to take them for the RVOT stenting after seeing that the infundibulum is reasonably good, only pulmonary valvular stenosis? Did you dilate those cases? Can you just elaborate on that balloon dilatation in this case, subset of patients?
So I think you're absolutely right. We've had, I think, a few number of patients where we, on the echo, are not convinced that the patient actually has got a substrate to spell, i.e. any infundibular stenosis, but has fair amount of pulmonary valve stenosis. Those patients, we have just gone and balloon dilated the pulmonary valve and not put a RVOT stent. That's number one. The second question you mentioned was about, sorry, I forgot the second question you mentioned.
Restenting.
Restenting, yeah. So what we have seen is some of the stents, if you had put a coronary stent, there has been some intimal growth, and sometimes there is a muscular development just underneath the previously implanted stent, creating a neo-infundibulum and causing further swelling. And in those patients, if the TAs are not good enough to repair, or the surgeons feel that there is other coexisting morbidity which puts them increased risk of bypass, then we have dilated those stents and we put another stent inside the stent because of the risk of neointimal proliferation, which has already been happening.
Okay. Neeraj, would you like to ask any question? Neeraj?
Chetan, excellent presentation. Just one question about that AVSD. Whenever we are doing a stenting in an AVSD, we have to go across the superior bridging reflex. That means we have high chance of causing the leakage. So how do you ensure that we don't really injure the subvalvular apparatus of the superior bridging reflex?
I think you're absolutely right. I think that is where that what you see, the angle, the way you cross the outflow tract is very important, especially in AVSD, because if you're not getting a clear crossing of the outflow tract, you have to recross it multiple times unless you get a clear outflow tract, because when you try to put your sheath up, you potentially likely to damage the supporting apparatus of the superior bridging leaflet. So I think you be very careful, and a lot of times that's the reason we use a telescopic technique. So at least, you know, once the catheter which is gone in easily, you can put the sheath over it, because if you try to exchange things over the wire, it can be quite difficult.
Dr. Dalvi sir, would you like to ask?
Yeah, I have one question for Chetan. You know, a coronary artery crossing right ventricular outflow tract has been one of the issues very commonly discussed when it comes to right ventricular outflow tract stenting. I would like to hear from you whether is it a contraindication or you have gone ahead without traumatizing the coronary artery. What happens? Because there is a difference between a native RVOT and a conduiting RVOT. So I would like to hear from you the relationship of coronary artery to RVOT when it comes to stenting.
I think actually anomalous LAD or a coronary crossing the RVOT is actually a good indication for considering RVOT stenting, because of the fact that majority of these patients will not have a translunar patch, they will need a conduit. So you actually want to get them to as big a size as possible to get a decent size conduit. Yesterday I re-stented another child who has got anomalous LAD. We implanted a stent about 4 months ago when the child was 3.4 kilos, now about 6 kilo. And we had to go in yesterday again because the child had some new intimal growth in the proximal end of the RVT stent, and put another stent inside there. But so far we have not seen any impairment of ventricular function or a significant coronary event after putting RVOT stent in anomalous LAD or any coronary crossing the RVOT.
Yeah, Chetan, there is one interesting question from Dr. Anand Subramaniam from Jaydeva. He worked with me earlier, my previous colleague. This question, I think, pertinent to the single ventricle path. I saw a couple of cases, even tricuspid atresia, some of the cases you stented RVOT or subpulmonary location, the stent was given in a single ventricular path. So, obviously, the stent is bigger, 5 millimeter plus. You tend to expect some kind of elevated PA pressure. Do you really think these cases will be suitable for bidirectional Glenn after RVOT stenting? Because one of your tricuspid atresia also you try to attempt to put one and heterotaxy syndromes, all these cases. I personally believe that these are relatively contraindicated cases for the stenting. Maybe Oliver can answer if his microphone is working.
I think still there is an audio issue. I'm chatting with him actually.
Okay, then Chetan can answer as well.
I think you're absolutely right. When you are doing anything with univentricular palliation, there are two things that you have to be careful about. One is there should not be any encroachment of pulmonary artery which jeopardizes the P anatomy. That's number one. And number two is essentially you don't want to have increased pulmonary blood flow where potential the risk of pulmonary hypertension and potential risk of not be able to do CP shunts. You do not want to go up to 5 millimeters. Sometimes the RVOT you can just to about 4.5 millimeter, and you can control that because you need only for 3 or 4 months, because CP shunts can be done at 4 to 6 months of age. So if it's a newborn baby, you can do this procedure and you need it only for 3 to 4 months period. So you don't need to go for 5 millimeter or 6 millimeter RVOT stent. You can cope with this for just coronary artery stents.
I think we have got most of the answers. If there are any questions
I had one more question for Chetan.
Okay.
Did your surgeons ever swear at you because you put in a stent in the RVOT?
I think this was happening in Mr. Braun's days, but I think our surgeons have become masters in taking out the stent in the RVOT now, because it's weighing the pros and cons. If you ask them to do a BT shunt, they say, no, you better put a RVOT stent. And so they don't have to complain to take it out.
My question to you is that how do they take out the RVOT stent? Do they take out completely, or it's only the anterior part of the stent which is removed?
So it's only the anterior part of the stent which is removed, because once they do that, they have to put a translunar patch. The posterior one can stay behind. You don't need to take that posterior portion out. And they will just all of that.
Yeah, I would like to just summarize how we are doing, because our center is one of the center we have done close to 36 cases. So if we have a good pulmonary annulus and infundibulum, we'll definitely stent only infundibulum, spare the pulmonary valve. That we adopted recently. If we have small annulus and infundibulum, we'll put a long stent going into the proximal MPA. If you have pure valvular and infundibulum is relatively lax when you are doing the angiogram, you do the balloon valvotomy and start beta blockers. Second point is what you said, the N blocking removal of the stent. If you do surgery lesser than 3 to 4 months after stent, most of the stent can be removed. After 6 months, our surgeon feels it's a very, very difficult, and he said he can't remove, and we are actually following them very closely and removing the stent as much as possible, because we don't know this metallic stent in the RVOT. That is the concern from our point. Probably we are going to learn from your center only, because you have got a large number of experience after Lee Benson group from Canada.
Can you hear me now?
We can hear you. We are waiting
Yes,
for your final comments and conclusion remarks of this particular talk.
Yeah, sorry, I had some difficulties earlier. There were a couple of questions. I mean, I think as Chetan has pointed out, we try to avoid the pulmonary valve in terms of pulmonary regurg. In patients in whom we want to have long-term palliation, so more than 3-4 months, we certainly would go for a Cook formula stent because we can redilate it. With regards to AVSD Fallow, I think it's very important to do an echo whilst you're crossing into the outflow tract. So if you end up with regurgitation then, or increased AV valve regurgitation, it's better to recross. I normally try not to use wires. There was a question about over circulation. Yes, it is true. You can always make the stent bigger. You can't make it smaller. So I would rather start smallish and then size it up later on. There was also a question with regards to tricuspid atresia, normally related great arteries, whether you can stent the BSD. I only done one case, and I would strongly advise against it, especially if you have to go through the mitral valve.
Thank you very much. If there are no questions, probably we can close this particular session. If you have any comments, I request Dalvi sir, Chetan or Oliver to give any of the comments. Otherwise, we'll just close this. And if we have, yeah.
Nageswara, if there is 1 minute, I have one question to ask.
We have 1 more minute, 2 minutes time for one, two questions.
My question is, what about antiplatelet or anticoagulation therapy pre and post stenting? And like you come across stent thrombosis in PDA stenting, Oliver, have you come across any thrombosis of the RVOT stent?
Well, we only use aspirin. We don't use dual platelets, antiplatelets. We have not come across any thrombus in the RVOT stent.
Okay. So we had one case actually after RVOT stenting. I don't remember exact time, 6 weeks to 2 months time, child came with thrombosis below the pulmonary valve. We stented only infundibulum in this particular patient. Child had acute gastroenteritis, followed by that child came with the thrombus, they stopped aspirin also. We took the child to open that thrombus. We could remove that, but child had very stormy course and we lost the child. That happened, I think, 6 weeks to 3 months after the primary stenting. So that's one experience we had, because our country, the temperature sometimes goes up high. Patients, they may not take adequate IV fluids sometimes.
I have one question. Can I ask?
Yeah, that will be the last question.
Yeah. Especially in this infants, there is the RVOT or even the tricuspid valve, which is acute. One case, I had a migration of the stent. And how do you tackle this migration or embolization of the stent? And especially when it is very stiff at the tricuspid valve, crossing becomes very difficult, you know.
Was that an acute embolization?
Yeah, while crossing the tricuspid valve and positioning across the RVOT, partially stented or something happened.
Migrated.
Technically, then stent got migrated distally into the right ventricle.
Yes.
So, did you come across such kind of cases? Do you have any solution for that?
Well, if the stent is still, you can't advance the stent into the infundibulum. So if the balloon is still on, or the stent is still on the balloon or on the wire, then the safest would be probably to basically recross the stent, have a balloon gently inflated, and then during diastole pull it slowly back into the right atrium and leave it in the IVC or retrieve it. But you cannot.
I retrieved the stent and put another one.
Yeah, I think that is a very good option of, if you have wire across still and balloon is there, maybe partially balloon take into the stent, inflate it, and slowly you can take into RVOT is a possible option. But I don't know technically how is it possible. And Chetan.
I think I just wanted to make one comment because I had an experience, I had a disaster yesterday. So the stents we have are the pre-mounted stents, and when we do a lot of manipulation, sometimes you have to be careful that the stent slide also slips it, and when you try to inflate it, it actually jumps out of the balloon when you're inflating the balloon, and what you have got is a non-inflated stent which has come off the balloon and ended on the wire.
Correct.
So basically that is where, and then when you're trying to get the same balloon onto the stent, you can't get it because you already inflated the balloon. So what I did yesterday was actually got that balloon out, put another catheter into it, change it for a smaller balloon after that, and made sure that I could actually dilate it distally to the stent and bring the stent back with partially inflated balloon. That's what I did yesterday.
That's really a good idea.
So thank you very much, Chetan, and thank you very much, Oliver, for your precious time during COVID time. And we are going to have the case presentations now. And I request Bharat sir and Neeraj and everybody to actively participate in questions. Chetan and Oliver, if you have time, we request you to stay back. So now Dr. Vijaylakshmi from Bangalore is going to present a case, the novel technique of turning nightmare into sweet dreams during device closure of VST. So madam doesn't need any introduction because she has been presenting massively in all international forums. So, ma'am, I request you to present the case. Then we will have questions and answers at the end. I request all presenters to complete 8 minutes so that you will have more time for the question and answer session.
Okay. This is.
We can see the slides. You can go into slide presentation mode.
I'm not able to make the Nitin Rao
take the cursor back, ma'am. No, on the cursor.
That lower one is covering that area, you know. I'm not able to.
Just take your arrow there. It will automatically go down somewhere.
Yes, that one. Yeah. Okay. No. A little up.
Go to view also. View also you can do from view.
Okay.
Go to view.
Yeah.
Press view.
Yeah. Oh, I'm not getting
slideshow is there. I can see slideshow from the view. Yours 6th or 7th after animation. Yeah, below animation, below. play from start. Okay, play from start. Press play from start. Play from
here?
yeah, from above.
No.
Yeah, yeah. Press
Yeah.
Anything is okay. Press.
Enter.
Okay. This was a 3 years old child. And this side, can I see my slide? I'm not able to see all these pictures.
Just drag those pictures outside the frame of the slide.
I'm not able to see my thing. So it was diagnosed to have a midmuscular VST, and on echo it was diagnosed as 6 millimeter, and QPQS was 2.2:1. So then we took the child for the device closure. I want you to look carefully. This is almost like a type A PDA, you know. The LV side is so huge and RV side is very narrow. And I would like you to, the audience to answer. Would you like to put a duct occluder or a VST device in this? So, however, I had already got a 8 millimeter septal occluder. So went ahead with the closure with that. And I thought it was across the VST and they released the RV side also. And once the RV side was released, and I thought the tilting was because of the catheter, the screw that was connected. But once it was released, how many of you think that it is in the right position or it is not right? And I felt it is not right and there is something wrong. And I was not able to make out what was the problem at that time. And then the problem started. Within no time, the child developed hypertension, severe bradycardia. We can understand hypertension with tachycardia, but in this case, there was hypertension with bradycardia, which was not responding with the atropine. So that's the time when the nightmare started. And so what do you do at such a juncture? And surgeons were not ready. The OR was not vacant for another 3 hours. We did the emergency echo, and the emergency echo showed that there was a bulging of the intra-atrial septum to the LV, indicating that there is a severe increase in the RA pressure. So then further we could see that the whole tricuspid valve was blocked by the device, and there was a severe tricuspid stenosis with tricuspid regurgitation, and that was the one which was causing the hypertension. And the gradient across the tricuspid valve was a whopping 30 millimeters of mercury. And what to do at this stage was a problem because the surgeons were not ready to take up the case. And then what I did was, we thought various methods. We thought, let me try to push it back. It is caught in the chordae, and try to push it. So the maneuvers that I tried, since there was no surgical help, tried to push it with the catheter, not possible. Made the guide wire into a made a hook-like thing, and then into the catheter so that it doesn't perforate. It didn't help. Then tried to dilate it with the balloon, and with the dilatation there was suboptimal result. To some extent there was a relief. The blood pressure was coming up and the bradycardia was much less. It was like almost like a bailing out, but it was not adequate. And at this time the tricuspid regurgitation had come down, the stenosis also had come down, but not adequate. So even trying with the 15x40 balloon did not help. So at this stage, I thought something has to be done to see that wherever it is caught, whether it is in the chordae or the valve, that has to be pushed back. So what I did was inflated the balloon and kept it at the tip and then pushed it gently into the position. How many of you think that it has migrated into the RV? Or how many of you think that it is all right? So this is almost like with the crane, lifting the device and pushing back into the position. And then the blood pressure came back, the bradycardia was not there, the child improved significantly. And when we saw that the patient was stable and the check angio was done, And this is how the device looked perfectly in the position. So whenever the right side device is deformed or angulation is wrong, many a times we think that it is because of the cable that is connected, but it is not that, and it can be caught into the chordae or in the tricuspid valve, and we have to be beware of that. And this is how the final result was: no TS, no TR, and the device looked all right. And so good times become good memories and bad times become good lessons. And that's how, I would like to conclude with the saying that, never lose heart. Try again until you succeed. And a novel method like this, where you literally lift the device and push it back into the position can be tried. Thank you very much for the patient hearing. Thank you.
That is really a wonderful demonstration of a bailout procedure. Fundamental question, one question is, when we do these kind of devices, when we see distortion, it may be good idea to push from the RV side with the cable. If you push that, the alignment and configuration will be better. You took a muscular VST device, I think.
Yes.
So that is the reason why there is, probably it went through smaller perforation in the beginning. It looks like 2 jets for me. So it elongated and then
probably because the LV side was so huge, and that's the reason, it just almost came across the valve, because we like to keep the tug, maybe the tug was more. So the point is well taken.
Maybe Bharat sir can give a comment.
I have 2 comments to make. One is, I cannot believe, Vijaylakshmi, that before release, there was no tricuspid regurg. Did you look on the echo for tricuspid regurg and stenosis before release? I cannot believe that there was none.
I couldn't hear the comment.
The comment, Vijaylakshmi, is that I cannot believe that before releasing the device, your tricuspid valve was perfect, and only after you released that, the tricuspid valve became dysfunctional. Difficult for me to believe that there was.
See, what happened was, when the catheter and the sheath was across, the cable was there, we did not concentrate much on the tricuspid valve. I was more bothered about the position, whether it is all right or not. So at that moment, it never came to my mind that it could be in the tricuspid valve, because the VSC is much lower down.
As an operator, you may not have the these things, but your echocardiographer, before you release the device, look at all the valves, look at the position, pericardial space before you release that device.
Okay.
That is what I feel is a good lesson from this. And second comment I wanted to make was, do you think that coming transjugular in cases like this would have made any difference rather than coming from femoral and going down like this? What has been your experience with muscular VSDs, which are located little posteriorly and little towards the inferior aspect of the interventricular septum?
Yeah, jugular I have done only when there was isolated dextrocardia. For the dextrocardia patient with the mid-muscular VSD, I went jugular. But otherwise, this was because it was more like a funnel-shaped one, and the LV side was so huge, and probably my device appeared very small compared to what it is. Otherwise, it wouldn't make any change.
No, I do agree with Bharat sir. If the VST is somewhat posterior location, extending or mid-muscular, if it falls below that trabecular zone, then I think jugular will align more than that. But I appreciate you managed it very well.
Absolutely.
Neeraj, would you like to have any comment, man? Your microphone is off.
Sir, I'll take some questions from the audience.
Yeah.
Most of them have congratulated Dr. Vijaylakshmi for the wonderful thing. There's one question that would it help if we take a aortic route rather than the venous route?
Ma'am, in these cases, would you like to go from the retrograde? That is the question somebody asked.
I don't know. From the time I've been doing, I do this way. So.
Okay.
Maybe Dr. Chetan sir, would you like to comment about
one more question? If you believe that prior, if that is a AV wall is close proximity, why not duct occluder 1 as a
Yes.
First option.
Yes, that's the question I asked, If you want to use the duct occluder, what size would you take? Because it was almost 14 millimeter on the LV side and 4 millimeter on the RV side. So would you like to take 10 by 8 or 12 by 10 or what size are you going to take?
What is the size of the VST?
The VST, the RV side was 4.5 and in the middle it was 8 millimeter and the LV side it was almost 12 millimeter.
10
Yeah,
by
10, 12, yeah.
10 by 8 would have been a good choice. Vijaylakshmi, even if it comes inside, there is no issue as long as it doesn't embolize on the RV side, and RV exit wasn't all that big.
Yes.
So maybe in the absence of double disc device, you could have probably avoided. I can't bet my last shirt, but you could have probably avoided tricuspid valve issue.
Oh.
And one more thing I want to make a point here, that imaging is very, very important.
Yes.
The VSD and the tricuspid valve apparatus in relation to the VSD, many times you will be able to make out that you could come into trouble if there is some tricuspid valve chordae attached near the VSD, if there is a muscular band which is crossing the VSD. So just because it is a small VSD, we cannot take it for granted. This is a general comment, Vijaylakshmi, not to you.
Yeah.
This is general comment I'm making.
I know. The point is well taken. I have done hundreds of them, but never had this sort of problem. Probably this anatomy was not a usual VST, where the usual VST is like just a hole, and this is like a funnel, and the anatomy, and it was more like a very loose tissue which came to the almost like to the RVOT. Otherwise, it wouldn't have happened.
Thank you very much, ma'am. I think the important lesson from this case is always you please try to define the AV wall, semilunar wall, proximity, and make sure by echocardiogram, baseline echo to see the tricuspid wall, mitral wall, and pre-release you should be very clear about these things. Thank you very much. I request Dr. Sreepal Jain from WCAT Mumbai. Vadia, sorry for that. Sreepal.
Yes, sir.
Sreepal,
hi, good evening, sir.
Sreepal is going to present a case, a stick in the neck saved my neck, a case of RVOT stenting. It looks, title is very interesting and encouraging. You'd like to see that, Sreepal.
Okay, am I audible, sir?
Yeah, very much.
Yeah, good evening, everyone. Very good evening to all the senior faculty members and all my colleagues here. And at the outset, I would like to thank LifeTech team, including Satya Usri, for kind of arranging these sessions and giving all of us opportunity to share our experiences. So what I'm presenting today is a case of RVOT stenting. So this was a 1-year-old male child weighing about 8 kilos who presented to our emergency services in a cyanotic spell. So the cyanotic spell was initially managed medically, after which the saturation improved a bit to about 63%. We did a bedside 2D echo, which showed tetralogy of Fallot with severe valvar and supravalvular pulmonary stenosis. The annulus measured just about 5 millimeters. And the main as well as the branch pulmonary arteries were severely hypoplastic. The Z-scores of branch pulmonary arteries was more than -4. So after initial stabilization, we discussed this case in our joint meeting with the surgical team. So we had 3 therapeutic options in front of us. So the first was a BT shunt, second was a Brock's procedure, and third was RVOT stenting. So after discussing with the team, we decided to proceed with RVOT stenting, given that it was a lesser invasive approach compared to the other 2, as well as multiple other studies documenting better as well as uniform PA size improvement post RVOT stenting. So we took up the child to the cath lab. We administered general anesthesia with endotracheal intubation. We acquired a 22 gauge cannula in the left femoral artery for blood pressure monitoring. We secured a 5 French short sheath into the right femoral vein. After having administered 100 units per kg of heparin, we started the procedure. So this was an angiogram taken in the RVOT with a 4 French right coronary artery catheter placed in the RVOT. So as you can see here, the pulmonary annulus so that's the pulmonary annulus showing a doming pulmonary valve, and there is a severely hypoplastic main pulmonary artery as well as the branch pulmonary artery. So the branch PA is measured less than 3 millimeters in size. The RV infundibulum was relatively well spared, as you can see in this picture. So we tried to cross the pulmonary valve with the help of O14 angioplasty wire. So with the JR catheter in the RVOT, we crossed the pulmonary valve and placed the plasty wire in the right lower lobe pulmonary artery. We took another similar wire as a buddy wire and positioned it in the similar place. Next, we decided to take a 6 French RCA guide catheter to take across our stent into the RVOT. So as you can see, the JR guide catheter is being positioned into the RVOT. So however, we could not advance the guide catheter beyond the os infundibular portion. And while taking the stent across the guide catheter, you can see that the guide catheter started backing out and clearly exposing the stent in the RVOT. Somehow we managed to take the catheter back up and retrieve the stent within the guide catheter. However, at this point of time, because of all these manipulations, the patient started developing hypotension. So we immediately withdrew the guide catheter, did a bedside 2D echo to rule out pericardial effusion or evidence of any tamponade, and the patient was started on adrenaline infusion at 0.04 mics per kg per minute. After having stabilized, we decided that we need to try another axis. So that's when and before that, actually, we thought that maybe pulmonary valve is one which is giving us trouble. Maybe it's the valve which is stenotic is not letting the guide catheter pass through it. So what we did was we took a Tyshak mini balloon over the angioplasty wire, and we positioned this 5x20 mini Tyshak balloon across the pulmonary valve and dilated it. But as you can see on this fluoroscopic image, there was not much of a waste visualized on that balloon. So after doing this, we again attempted to pass the guide catheter, but again were unsuccessful in doing so. So eventually we decided that we need to probably try through the neck axis and see if that would be more coaxial for us to allow the catheter to be positioned in the RVOT. So we access the right internal jugular vein, and so here, as you can see here, there is a JR catheter which is again positioned in the RV body, and with the help of a 035 Teremo wire, we have crossed the pulmonary valve, and then we position the Teremo wire in the right pulmonary artery. After this, we tried to pass the JR catheter over the wire into the pulmonary artery so as to change the wire, but however, again, we were unsuccessful. So instead of the JR catheter, we took a 4 French Co catheter, which is similar to a glide catheter. And after much maneuvering, we were successful in passing the catheter deep into the right lower lobe pulmonary artery. So next, we changed this wire for a regular 035 Teremo wire, which was positioned in the right pulmonary artery. And now this time, we decided to take a 6 French Mullins sheath rather than a guide catheter, and were kind of successful in taking the Mullins sheath right up to the pulmonary valve orifice. After having done so, we did a sheath angiogram to make sure the position of the sheath tip. And as you can see in this angiogram, it was right at the pulmonary annulus level. With this sheath in position, we passed another angioplasty wire and positioned into the right lower lobe pulmonary artery. After this, the Teflon wire was removed, and over this Teflon wire, we took a 5x18 millimeter Cogent peripheral stent. And now, as you can see the stent, it was quite easy for us to pass the stent across the sheath into the main pulmonary artery. After this, we withdrew the sheath back a little bit to allow us to do a check angiogram. And as you can see in this angiogram, the stent appears to be quite distally placed, encroaching onto the bifurcation of the pulmonary arteries. So we withdrew the stent. At this point of time, you can notice that there is a slight kink in the Mullins sheath as well over here. Now here, the stent position appears to be too proximal, just at the orifice of the pulmonary valve. So we pushed the stent a bit inside, and eventually we inflated the stent. So the stent was quite well inflated, and this is the final angiogram where you can notice that the stent is well positioned across the pulmonary valve. There is good antegrade flow across both the pulmonary arteries. So the saturation immediately improved to about 88%. The child was extubated after about 6 hours and eventually discharged after 48 hours on oral aspirin therapy. Unfortunately, the child was lost to further follow-up and we don't know what has happened to the child. So while reviewing the literature for RVOT stenting, I came across this study by Dr. Chetan and Dr. Oliver's team, wherein they had published about 52 cases, of which about 6 cases they had done through the right IJV approach. However, the paper did not clearly mention about the indications for the IJV approach. So since both the faculties are right here in the forum, I would like to really put across these 2 questions to them. Is that one, was there anything else that I could have done to, kind of allow me to do the procedure successfully from the femoral route? That's one. And second is, which cases would you consider really taking the IJV as the first approach rather than, being as a backup plan? Thank you for your patient listening.
So straight away we'll ask Chetan and Neeraj also to take some of the questions. They both are the panelists for this particular session. Maybe to begin with, Chetan can start.
Yeah, I think, hi Sreepal, it's a fantastic learning case. I want to make 2 comments. I think the question is right. I saw you putting your guide catheter over 2 coronary wires and you were struggling to get it in the RVOT. I think that is one thing to be very careful about, trying to push the catheter up, because that is what has caused perforation in some of the cases in our early initial experiences. Whenever the catheter you're trying to push, especially something like guide, which can be quite stiff, the edge of it potentially can perforate the RVOT if you're going there. Sometimes those situations probably better to do a telescopic way in which you actually put a 4 French catheter or a 5 French catheter through that over the wire and then try to move it. So it almost acts like a dilator. But obviously you can't have much of a shoulder, and that is what the worry is. The shoulder potentially can perforate the RVOT. Yeah. So that's the reason why we've been saying is use a 4 French flexure sheath, use the 4 French catheter to get into the RVOT first, and over the wire and with the catheter, then put the sheath over. And if you're preferring to use a stick guide, then you should have a catheter inside it rather than just try to get it over the wire itself. The question about neck puncture, I think two comments about that. We have done those, number one, in patients where there was an interrupted IVC coming to the SVC. That's number one. But we also found actually it's better to use the neck approach in very small infants, because of the fact that the small heart, the splinting of the heart is a lot more when you go from femoral or venous side of things, but the neck gives you a nice curve, almost like a U, and it's a lot more stable. During the baby is a lot more stable. So smaller babies, we tend to prefer the neck approach. I don't know whether Oliver is still on light, whether he has any comments to make.
I will just give a comment on that. Actually, we had a similar situation, some of the cases, Sreepal, but I don't take 2 PTCA wires. You can actually take a 3-2 wire or 3-5 wire to track the catheter all the way to MPA. Or else alternatively, if you are taking a PTCA wire, take a balloon, the PTCA balloon, inflate the balloon distally, and over that you can easily track it. These are the tricks, but you may not be successful in sometimes. From the neck, we also did, but I will never take this Mullen's sheath when we are going to RVOT. I always take a flexor sheath or Balkan sheath or anal sheath. These are the braided sheaths which are really good. I think we'll take opinion from other. Dr. Vargan also there, and Bharat sir is there. Neeraj.
Yeah. So sorry. Well, I actually in my country, RVT stenting is very limited case number because the surgeon here doesn't really like it. So honestly, I have very limited experience on that. But I totally agree with Nageswara, because if we got a problem with the advancing the catheter, maybe using the balloon as a guiding, dilator, that would be very helpful. Yeah, but also when you have a very acute curve, and using the braided sheath would be much better in terms of prevent kinking, and also give you a better chance to get the stent in the right position very nicely. But yes, very successful case. Thank you for sharing.
Actually, Pallav, excellent case. Same word I
Thanks.
would emphasize that even Chetan has showed in the article that using a mother-child techniques helps. So maybe using a RCA and taking a sheath across. Vis-a-vis, if we take directly a guiding catheter, there is a lot of discrepancy between a coronary O14 wire and a diet. So that causes a lot of mismatch and problem in crossing. Dr. Kannan has asked whether shallow aleocranial or caudal view is better to properly position the stent without protruding into the branch.
So what we have realized is RAO actually provides a very good view where you can actually make out the valve as well as the distal bifurcation for us to allow the exact positioning of these kind of stents. So that's the reason in this particular case, I actually stuck to just the RAO view.
No, that's a very good view. RAO and lateral also is very good. Let us take opinion from Dr. Oliver Stumper also. His microphone is on. After that, Bharat sir can give a final comment. Oliver, would you like to give a comment? Did you see the case?
Oh, I'm up in Wales, and the internet connection is pretty dreadful.
Audio is not.
But with regards to angiography,
We are getting a piano-like sound, so audio is not good. But by the time we get a proper audio, probably Dr. Bharat can give a comment.
No, I think it's a good idea to track either the sheath or the guide with a balloon as a dilator. That's a very good idea. At least should be attempted. It was a great case, really a good case. The second comment is that, we are little reluctant to use jugular approach. We means including me. As a routine approach in small neonates, especially when we are dealing with right ventricular outflow tract. Why do I say that? Is because right ventricular outflow tract is far more horizontal in neonates as compared to post-neonatal. And believe me, coming from an inflow which goes like this and then outflow which goes like this is quite difficult. I think it is not a bad idea to, if you use it routinely in newborns who do a lot of neonatal work, I think you will get used to IJV as a first choice. And it's not a bad idea that when you are dealing with RVOT, using IJV as a primary choice. Maybe I may be a little overstepping, but that is what I think. And the third question I wanted to ask you, that looking at these pulmonary arteries even at the age of 1 year and some of the peripheral PAs, was this child syndromic in any sense, either phenotypically, or you worked him with some chromosomes or something to find out whether he was syndromic?
No, so clinically, the child did not have any dysmorphic features as such. But as you rightly mentioned, looking at these kind of pulmonary arteries, even at the age of 1 year, we definitely suspected a chromosomal anomaly. Unfortunately, because of financial constraints, we could not pursue any further investigation in this child. And as you noticed that this child was actually lost to follow-up.
And it would have been really interesting to see.
Yes, to see
how
whether
the pulmonary arteries grew,
absolutely,
and whether they grew at all.
Yes, absolutely. So unfortunately, we don't have any clue as to what has happened to this child.
Thank you.
Thank you, sir. Thank you, everyone.
Thank you very much. Neeraj, would you like to take over from here?
Actually, not sure who is the next presenter, so I'll.
Usha ma'am, can you share the?
So the next presenter, Dr. Usha M.K. from Bangalore. She's from Jayadeva Institute of Medical Sciences. She's working with Professor Jayaranganath. And Dr. Usha is going to present an RVOT stenting, age no bar. I think they have done a lot of cases of RVOT stenting as a palliative in the grown-up patients, even adults. I remember that they were presenting and Dr. Jairangana was showing even in as late as 40 years of age. Dr. Usha, please go ahead and present.
Yeah, good evening, sir. Thank you for this opportunity. I hope I'm clearly audible.
Yes, you're clearly audible.
Yeah, thank you. I would like to present a cluster of cases performed at our hospital by our team. So I'm going to present them in parallel. There are different subsets and different age groups with a different set of symptomatology and pathophysiology. First child was a 4-year-old boy. He had undergone surgical VSD closure at around 1.5 years of age. After that, initial follow-up echoes showed that there was no VSD, but there was a moderate RVOT obstruction with a gradient of around 40 millimeters of mercury. This child was lost to follow-up after 4 months after surgery. And after 2 to 3 years, he presented with symptoms of dyspnea, fatigue, and pedal edema. And when he came, he was edematous. He had elevated JVP, a hepatomegaly, with the ejection systolic murmur. He had a RVS3, and ECG was showing RVH with RV strain. The second case was a 32-year-old female. She was diagnosed to have a heart disease from childhood. She has not undergone any treatment for the same. She had symptoms of extreme fatigability and dyspnea, which had worsened in the last 6 months. She was cynosed and clubbed. Saturation was 48%. She also had features of congestive heart failure, and ECG showed features of RV strain. The third case was a 21-year female with 28 weeks of amenorrhea. She was referred in view of murmur and symptoms. She had dyspnea on exertion class 2 to 3. Her saturation was 85% on room air. She had a harsh ejection systolic murmur. At that point of time, the fetal echo was normal and the fetal growth was good. So we have 3 case scenarios. A post-op patient who had an RVOTO who was presented in failure. And the second case was, as I'll show you the echo, it was a case of tetralogy who was again common failure. What is the cause of failure? Is it just the hypoxia? And the third one was a pregnancy with a native RVOTO with hypoxemia. I'm sorry, I don't have echoes for the 4-year-old boy with RVOTO. He had a grossly dilated RA-RV with severe RV dysfunction. There was severe narrowing of the infundibulum. The echo gradient was around 110 millimeters of mercury. There was no residual across the VSD patch, and he had moderate tricuspid regurgitation. The second one, a 32-year-old female, her diagnosis was Tetralogy of Fallot. This is the echo picture of that patient. You can see the grossly hypertrophied and dysfunctional RV. And if you observe carefully, you can see why this dysfunction is so severe. Can you see here, this large VSD, there's a septal aneurysm which has developed, and the VSD has become restrictive. So with the color flow mapping, there is actually a right to left shunt across the VSD, and there was a gradient of 30 millimeters of mercury from RV to LV. What about the RVOT flow? There was just a trickle of flow with very minimal gradient. The IVC was dilated and non-collapsing. So I'll go ahead with the procedure. This is the first child who was a 4-year-old boy. I think this X-ray picture itself tells the whole story. A grossly dilated heart, enormous RA. You can see the highly trabeculated, poorly contracting RV. This is the angio with the pigtail catheter in the AP and the RAO view. You can see the reduced function. You can see there is moderate tricuspid regurgitation, and you can see the extremely narrow RVOT at this point. So we went ahead, and this boy was again a poor candidate for surgery at this point of time in view of the severe RV dysfunction and his poor clinical status. So we had to stent him to make him a better candidate for surgery at a later date. So we used a 8x29 Omnilink stent, which goes easily through a 6F guide catheter. So we positioned that across the RVOT and inflated. The RV systolic pressure, which was 112 millimeters mercury, immediately dropped down to 45 millimeters of mercury. Over a period of 1 month, his RV function improved and his failure features resolved. Actually, this procedure was done 1 year back, and he came for follow-up, and he was operated 3 months before. The child was operated after 12 months. He had a normal RV function at the time of surgery. He's been discharged and he is doing well on follow-up. So this was the second case, which was an adult, 32-year-old with a TOF with a restrictive VSD, who was extremely cynosed, very polycythemic, with platelet counts of only 50,000. And she was again a poor candidate for surgery in view of her coagulopathy, her severe RV dysfunction, and hypoxia. So she had significant kyphoscoliosis. So we did an angio. This is the pigtail angio. You can see actually her branch PAs were very good. But because of the severe RV hypertrophy, there was severe infundibular narrowing. So we decided to go ahead with stenting, sparing the pulmonary valve. So we positioned the stent just below the pulmonary valve and we inflated the stent. So at that moment, the best stent size we had was a 10x40 formula stent. And as soon as her RV pressure was suprasystemic, she had an aortic pressure of 104, whereas the RV pressure was 150 millimeters of mercury. This immediately fell to around 100 millimeters of mercury after deploying the stent. Her saturation from 48 to 50 jumped to 85% within a day of stenting. She has come for follow. Right now it's 3 months post stenting. Her RV function is very good. Saturation is 85%. And right now she's a good candidate for complete repair. So this is just a comparison video of the echoes. Sorry. So you can see the pre-procedure, how there is a severe narrowing of the VST with only a right to left shunt from RV to aorta. And once the procedure is done, there was a bidirectional shunt with improvement in saturation. Here you can see the stent in the RVOT with a decent flow. 4 months follow-up, saturation 85%, good RV function, significant improvement in the functional class, and referred for surgery. The last case, which I mentioned, was a 28-year-old lady with 21-year-old lady with 28 weeks of amenorrhea with hypoxemia of 85% saturation. If we continued the pregnancy, there would be risk of a fetal IUGR, fetal IUD in view of hypoxia. She would have complications of RV failure, embolism, even including mortality. Surgery again would carry a high risk. So we decided to do a palliative RVOT stenting in this patient. So her initial RVOT gradient on echo was around 120 millimeters of mercury. You can see the severe narrowing in this view, severe narrowing of the RVOT quite a distance away from the pulmonary valve. So this case we had done some time back, almost 4 years back. So at that time we had a Palma stent 2910. We mounted the stent on a 1440 Atlas balloon and we stented across the RVOT. RVSP was 170 millimeters of mercury and it dropped to 45 millimeters of mercury. And by next day, her saturation improved from 85% to 92%. So you can see the post-procedure echo. There is a good flow across the stent. The gradient across the stent was around 25 millimeters. Saturation was 92%. She had a normal vaginal delivery. Baby weight was 2.8 kgs. So in conclusion, RVOT stenting can be a bailout procedure in instances of severe RV dysfunction when it is a high risk for surgery, when surgery is contraindicated. We have done some RVOT stenting in adult tops with severely hypoplastic pulmonary arteries, and we have found that the Z-scores of the pulmonary arteries have improved significantly at an interval of around 6 months. And once the stenting is done, surgery can be considered at an interval of 6 to 12 months. Thank you.
Excellent case, Usha, actually. I will take the questions from the house. Most of the questions have been answered beautifully by Oliver. There's one question, talk with severe biventricular dysfunction. Any stent experience in child or adult? Talk with biventricular dysfunction.
Biventricular dysfunction we have not had. 1 or 2 patients only with RV dysfunction we have stented.
One of the cases you demonstrated of Hoffman variant with RV dysfunction, probably RV function helped. Do you routinely pre-dilate the stent whenever pre-dilate the RVOT when you take it for a RVOT stenting, or you take a stent?
For this patient we didn't, but like I mentioned, some of the adult of patients with hypoplastic PAs, extremely tight RVOTs, when the stent, we are not able to negotiate the stent. Yeah, we have pre-dilated with a non-compliant balloon, small peripheral balloons, and then we have crossed with the stent. I mean, it was not on purpose, it was because we were not able to negotiate the stent.
Question which is repeatedly coming, which we'll like to ask Oliver also, he's answered. What is the chance of stent fracture in severely hypertrophied LV? So probably Oliver has also answered more than 30 kgs, the chances are more, but any particular stent or any particular variant where stent fractures are more common?
Neeraj, Jairannath here.
Dr. Jay, yeah.
Neeraj, I think you're right. Absolutely. This also we almost, I mean, most of the times we are also worried about the stent fracture, but somehow it doesn't happen, you know, especially with the peach. Palmar stent, it never used to happen. Actually, in the olden days, we always used to put it. We obviously we are worried about putting a formula stent. It could happen. That's a theoretical possibility. But I think in only one case which has happened in an old patient more than 30-35 years. I don't remember exactly what the clinical scenario, but yeah, ultimately that boy underwent surgery. But that's a definite risk, and that's a possibility.
And most of the times, RVOT stenting is done as a palliation.
Palliation, exactly.
So, you know, you don't wait long enough for the stents to fracture. Once the patient improves clinically and hemodynamically, you tend to go in and repair these patients.
Yeah, it really doesn't matter even if stent happen, I mean, fracture happens, really.
I had one comment to make, Jairangna.
Yeah.
And Usha, great presentation. In that first case, you know, which was repaired. My question to you is that, did you attempt a balloon dilatation, or you thought that this was not worth balloon dilating and directly go ahead with stent?
No, we were very sure, Dr. Bharat, that it is a infundibulary narrow, more of a muscle issue rather than the valvular stenosis. We are very sure about it.
Because angiographically it looked pretty distal to me. That is why I asked you.
Yeah, I know. Angiographically it is difficult because its RV was so much dilated. We are not able to image in the angiogram. The echo-wise, we are pretty sure the valve was okay. It's just below the valve, the muscle bundle.
The second comment I wanted to make, in that patient, you selected a 8 millimeter stent.
Arm dealing,
And there was a residual gradient of around 40 or 45. I don't remember the number. It was a good strategy. Why I wanted to make this statement is because not only in post-operative, but even native RVOT narrowings, even valvular, if you try and repair these RVOTs completely in these adult patients or, you know, adolescents, you can land up with florid pulmonary edema because their lungs are not used to that kind of flow. So it is excellent strategy to leave behind some residue, let the RV recover a little bit and then go back again and let the lungs get used to it. Otherwise, I have lost one baby like this maybe 10-15 years back, and I have learned that lesson, that critical RVOT obstruction in adolescents can be really a very traumatic experience.
Correct.
Just wanted to make a comment.
No, this is absolutely
and Professor Jairangnath, these are really wonderful spectrum of cases, very high risk cases. What you presented, the first patient cardiothoracic ratio is a 0.7. Do you have X-ray post procedure sometime during follow-up? It's interesting to see that X-ray actually.
Yeah, sir, actually he underwent surgery 3 months back. I can share it with you later.
That's fine. I think these are wonderful cases and very high risk. I found that first case, probably you should have gone straight away from jugular because looking at the tortuosity of the circuit, but you could manage to go through 6 French guide catheter using a 8 into 15 or 20 stent. That's only link you could be able to do that. But looking at that anatomy, I was thinking that jugular would have been an option in that particular.
Dr. Oliver, can you hear us?
Yes, I can hear you, but I don't know whether
You're audible.
my mic works. Can you hear me? Can you hear?
Yeah, we can hear you, but a little bit of a
Can you hear me? Sorry.
Satya, this is the problem of the bandwidth of the Wi-Fi.
Right, true.
Sometimes it's not possible to transmit.
Yeah, it's a network.
Yeah.
Sorry about it.
Can you hear me now? Can you hear me now?
Yes.
Yeah. There were a couple of questions about stent size or stent material in older patients. Certainly, the Cook formulas we used very successfully up to about 30 kilogram. Above that, I would personally go for cobalt chromium stent. And there was also a question about migrate stent. And yes, we have seen that. So basically, and in that I've done a couple of times is basically use a larger stent, but only hand inflate. You end up with some sort of dumbbell shaped. Yeah. Any other questions?
Yeah, we have language a little bit of the technical aspects, but Usha or Jairanath can answer that question, then we can go to next presentation.
Dr. Nitin Rao, you can share the screen, please.
Yeah.
Neeraj?
Yes, sir. Actually, I'm not. Dr. Nitin is a versatile presenter from Hyderabad. Has done so many wonderful presentations. He'll be presenting on hybrid PDA stenting. Nitin.
Just a minute. Am I audible?
Yeah, you're audible, Dr. Nitin. And
Yeah,
your slides
Nitin, you are visible and audible, very clear. And the slides also are seen very nicely. Nitin Rao is from Star Hospital, Hyderabad. We were colleagues at some point of time at Care Hospital, and he has been doing a lot of complex interventions for the past 15-20 years. Nitin, please go ahead and present.
Thank you, Nageswara. Thank you. I'd like to say thanks to Life and the whole team for this opportunity. It's really good. Nice to see Chetan on the same. We were colleagues in Wadi a long time back. I just want to present. Sometimes you see cases in crops, you know. So we did we got a few diseases that are a bit out of the way, so we just thought we'll present. We had we have some things go out of the way, so we have to be prepared. We had a 2-day-old neonate deliver at normal delivery, birth weight of only 1.9 kgs, doing well, and crashed on day 2 with a saturation of 70%, and cyanosis, shock, acidosis. Echo was researched in the NICU, but echo showed a large PSD and a single semilunar valve, single great artery, so obviously truncus arteriosus. But the arch was not well dilated, it was very vague, so probably intrapid. So before we could do a CT scan, they started a prostatic infusion and sent for CT angio. CT angio, if you can see, is something what is the one drug A4 classification. Something very rare. You see the truncus heart, you see the trunk here, and it continues as the pulmonary artery, whereas the ascending aorta comes separately. And usually that's intrapid. It's very rare anomaly, but you see that. So when you see the posterior view, this is the trunk here, and the both pulmonary arteries coming separately. The ascending aorta is coming and is separate. It's intrapid. So this is the old classification that we all used to. This is the Colliton and Edwards classification that most of us know. Type 1, Type 2, Type 3, and Type 4, which is not used nowadays. The Banpa classification, Type A1 is the same as Type 1 in College Edwards. Type A2 is like Type 2. Type A3 where you have RPA from the ascending and LPA from descending. Now this is the Type A4 that I'm talking of. We have a trunk which continues as the main pulmonary artery and then at the PDA. Whereas the arch comes, ascending aorta comes separately, this is due to intrapid. So this is a child that we had. These are the images. We showed a very nice large PDA continuous descending aorta, and these are the CT scan images. So the management, we had two options. Surgical would have either you do an arch repair plus a truncal repair. And a small baby 1.9 kg we thought was very, very bad risk because of morbidity, and obviously it would require redo surgery as well. So we thought whether we should do something like hybrid approach, like PDA setting and a bilateral PA band in the same setting, and schedule for truncal repair later when the child grows up, when it's less risky to take up. And because we thought that it's a better risk to do a Percutaneous procedure because it's 1.9 kg. The child was also in septic, was being treated for neonatal sepsis in the NICU. So after parents were counseled and we told them both options, prostacyclin was stopped for 12 hours prior to the procedure. And in the cath lab under GS, sternotomy was done, the PA was exposed. And PA was very nice and that the surgeon took a puncture, we took a puncture and the wire went distally into the across the PDA and disseminated very well. And we passed a 5 French sheet over the wire and the angiograms were done. We had a very good site, it was very good for this is the sternotomy, this is the sheath across, and seems to be okay. CATH, the PDA measured 3 mm diameter and 9 mm length. And it was good size aorta, good size PDA, so it looked quite okay. Again, this is the sheath across from the PA into descending aorta. And this is the first shoot that looked like a nice duct. And there was a left subclavian artery coming here, some stenosis with it, probably just a pinching effect. Unfortunately, when we were trying to get the wire actually slipped out, we thought we'll cross, but we thought we'll take a shoot again. As you can see, the wire has come out, but seems to be okay. And then as we tried to pass, probably the PDA wasn't spasm. There was some contrast held up here. Not very sure what we're doing. You can't see the PDA going to PDA descending out quite bad. And over time, it actually looked worse. There was a small shoot coming here, but I didn't think that was a PDA. Whether we had caused some perforation or something, we are not very sure. It was quite, baby was beginning to crash. We really didn't know what to do. And if you can see, there's a held up contrast is held up, is probably dissected also. So you've got a situation where you've got 1.9 kgs baby, you've got a spasm of the PDA, dissection of the PDA. It's a very bad situation. And you can see the AP view, the wire is going across, but I'm not sure whether this is really descending, not very sure. It didn't look good. Because the PDA is actually coming in this direction, the wire is here, it looked quite bad. So we decided to restart the coronary infusion. And then we thought we'll do a femoral approach now. Femoral approach we actually want to avoid earlier because of 1.9 kilos. But we started and it seemed to have improved. The flow seemed to improve. And like you see now, the PDA has actually opened up very well. And we could pass a wire across from the aorta to the PDA. Since our sheath wasn't across, we thought let's try the sheath also, and we could pass a wire from the sheath as well, PA as well. So we had a very good access. It looked quite good, but I'm not sure what the dissection was. At least we had an access across. We put the sheath, a short 12 mm sheath stent across, and it went in position. Lot of held up contrast. It looked bad, but we had no option. And the person was descending out. The wire was good in descending out. It looked quite to be okay. And then we went ahead, and we went and we confirmed it was good, and we inflated the stent. Looked to be okay. And these are the wires for the PA banding that we put on both sides. And this is the last. If you can see, the stent is in position. There was some dissection, but if you can see that small contrast with the wire is still there. So whether we had a perforation, we don't know. But baby was stable. The PA banding was done, and then the baby was stabilized. Shifted to PSU, extubated on day 3. Continued antibiotics. They have a lot of oliguria, so need to dilate for 2 days. And the follow-up echo showed a patent stent, very well-felt pulses. There's no fluid collection, no issues. And the pulses were very felt. But unfortunately, the baby didn't do well. It had sepsis and it expired on day 10. So we lost this baby because of these issues. And subsequently, a few days later, we had a similar case. Always cases come in crops. It was a 2-day cases, 2 days, but this was 2.6 kilos. It had absolutely same anatomy, like truncus had Vanprag A4, but this had a diaphragmatic hernia as well. There's small amount of diaphragmatic hernia also. So this was the same. It was referred from another hospital, started on coronary infusion, and we thought we'll take up the same procedure. Family was quite okay with that. And since we had a bad experience last time, we went ahead and then we finished the procedure as fast as possible. We got the wire across. And you can see this angiogram shows very good PDA, very good descending aorta. We do the quick procedure and we position the sheath across, the stent across. This is also a short stent about 12 mm. And it was inflated. It went off very well, no issues, quite comfortably. And this was the last sheath, the stent is in position. Subclavian artery does not seem to be affected. And a bilateral PDA banding was carried out. The procedure time was 90 minutes. The sternum closed on second post-op day. This patient went up very well. This patient was stable with good pulses and extubated post-op day 2. Post-op, the echo was a widely patent stent with a very good drain across pulmonary arteries. Diaphragmatic hernia, we thought we'd closely monitor. This is the extra time of discharge, shows a very nice big stent here. Then baby went home and came back for follow-up at about 6 weeks of age. He was doing very well. but there was a lot of apprehensive patients. Parents were very apprehensive. They never came back for first follow-up further that. And we came to we called them again at 2.5 months. The baby had a sudden death, but there's no follow-up. They didn't come to us. We had to follow-up, so we have no idea what happened. So this is one of the 2 cases we had. One went well, with the other one had a major problem. To summarize, just like the hybrid period stenting is feasible, select subset of patients, but you have to be very careful. You have to always look landmark. The first case we didn't put a feeding tube, that would have been good landmarks for the aorta. So it can guide give you a pathway where you can go up to the stent. That would have been a major advantage. We did that in the second case, it went off very well. You have to be very careful. Complication of this, it's a very non-forgiving subset. You have to be very careful. So we've had 2 cases. One went well, but the other one we lost. Thank you. Hello. Sorry.
Nitin, both the cases are very complex and high-end interventions, hybrid intervention. I congratulate you. Did you do total correction for the first case, or they did not come? Or which one case had a sudden death? What happened to the other patient?
The second patient we lost to follow-up because the family, they came for the first follow-up at 1.5 months stage. But then family, they didn't come for follow-up the second time. And I believe the patient had a sudden death at 2.5 months of age. But they didn't come back with it. We lost follow-up, but this patient also didn't survive.
What was the saturation pre-discharge in both the patients? Because to know the PA banding, what the saturation we accepted in both the cases?
Yeah, both of the first case we lost the baby. The saturation came up to 84. Okay. The second one saturation was about 70-75. The grades were very good. We had a good of 20-25 across both pulmonary arteries.
Chetan. Shiva is there. Shiva also there. Shiva, would you like to give a comment before Chetan takes?
Yeah, I was enjoying Nitin's presentation. Nitin, let me just give my views on this hybrid stage 1 NOR.
Yeah.
The moment you do the sternotomy,
this is a truncus, Shiva, not
truncus. Correct. Yeah. No, the issues that are present in the hemodynamics is pulmonary over-circulation and systemic under-circulation. So before ensuring that the ductus is being stented, the pulmonary over-circulation needs to be controlled. So the first step should be take a pulmonary artery banding and do the pulmonary artery banding with fully prostaglandin running in, so that you have a perfectly controlled pulmonary blood flow, reasonably preserved systemic blood flow, and then you cut off the prostin. Then you start the procedure. So I don't know whether I was hearing you very clearly. It was like the stenting was followed immediately later by the PA banding.
So the first case we did the stenting first and PA band setting second. Yeah. But the second case we did the PA band first and stenting later.
It's actually easier for the surgeon to manipulate loop around the LPA, loop around the RPA, and get the bands if there is no metal that is sticking in the region of the duct. Right. So that is number one. Number two is the amount of ductal dissection that happened possibly due to wire slipping out, and then you are trying to manipulate. One of the issues about this sheath in the main pulmonary artery, which has been anchored with a purse string, the quantum of the sheath that is going to be beyond the region of the purse string into the lumen is going to be just about 1 centimeter or 1.5 centimeter maximum, because beyond that the ductus will start. So the purse string needs to be extremely tight. One of the surgeon needs to hold the sheath very carefully, and if he inadvertently allows the sheath to go in a little bit deeper into the main pulmonary artery, it will be dissecting onto the mesangial soft tissues of the ductus and creating a lot of staining that you are about to show. So in fact, at that particular level, the moment the purse string has been taken and the needle has been introduced, the wire is introduced and the sheath is introduced, the sheath should have a stitch about 1 or 1.5 centimeter proximal to the distal tip, and the stitch should be permanently visible from the main pulmonary artery end. And there is no way in which the sheath can inadvertently pass deeper and try to damage the ductal tissues. So,
Yeah.
but I would say it was a good effort on both the patients, and it was
I think Shiva, that's what happened. The first day, the probably sheath went in a little bit, and that's what caused it. Like you can see, it's slightly angulated. No, that's probably
what is recommended is you take the sheath, you anticipate from the level of the main pulmonary artery to the proximal end of the ductus. That means the pulmonary end of the ductus. What is the
less
length?
than a centimeter.
At the half of that length, you put a suture on the sheath outside, and so that suture will be the landmark beyond which the sheath will not advance. So the sheath should not touch the ductus. The ductus is basically a soft mesangial cushion tissue, which is very friable because of the prostrin that was running till about a few minutes before. So in that particular case, it is important to ensure that I think actually all the millimeters count here in terms of the distance between the MPA and the duct.
Yeah. The prostrin was stopped 12 hours before, but it was a very huge PDA, and it is friable. Neonatal PDA, obviously, very friable.
The patient would have been much more controlled if the bilateral PA bending was already done.
Was done first, yeah.
Chetan, any comments from your
Yeah.
side?
So I think it's interesting cases. Nitin, fantastic presentation. I think I would slightly talk about physiology over here with truncus anatomy. I think as Siva probably emphasized, the balance between systemic and pulmonary circulation, and a lot of this truncuses do die a sudden death because of coronary perfusion, which gets compromised when the pulmonary vascular resistance falls. And I think obviously in our center, we would probably have this child would go straight for surgery. They would go for implant repair and truncus repair. I would just like to take it out of the context in terms of the technicalities of the ductal stent, in where the duct is responsible for systemic circulation, and in the you can say it in the same breath that is probably the analogy is probably a hybrid Norwood. So we don't do many hybrid Norwoods, but whatever little we have done, we actually get the surgeons to do the PA band first. Right. And keep the child on prostrin. We want to make sure that actually the PA band is good enough, the tight enough. You actually achieved a good enough, restriction of pulmonary blood flow before you go ahead and do a ductal stenting. So we would actually get this child back later on, get it to the cath lab after basically deciding when you have to go for ductal stent. So we would make sure the PA band actually are in position, are getting good velocities on echo before we actually do the ductal at the same time. I don't think we have done any truly hybrid ductal stenting along with the surgeons in Norwood situation, because anyway our surgical Norwood program is good, so we don't do that many hybrid Norwood.
Right.
Only one comment. Sir, are you talking?
Means after you I can, because my experience is zero, but what I have seen and heard I could probably share with you people.
Go on.
Basically, if you see the strategy of hybrid Norwood, the Gissen experience where Dittmer was the chief, they would only band the pulmonary arteries in the theater and then bring the patient in the cath lab from the theater and then stent in hypoplasia. I'm talking about. In truncus, things are a little different with interruption. The second issue is that one of the things when you have such a large ductus, many groups use a self-expanding stent vis-a-vis the balloon expandable stents. Right. And they have probably the length and the chances of migration are probably minimum, and the procedure is very short and can be easily done in the cath lab. So these are the two things probably I wanted to say. Because in these small babies, working with the surgeon with that small field, we are not as used to. So getting them in the cath lab and stenting them may be a good strategy in patients like this. Right.
Yeah, I just want to give a comment to Neeraj finally. We also have done two cases. Two cases did not go for the complete repair at any time. What we adopted is, we had experience of carotid stenting using the same groin sheath. Over the period of time, we realized that the sheath which is most worst and dangerous is the groin sheath. Wherever you see dissections, it will have sharp edges and cause damage. So that's the reason we adopted in that one particular case is arrow corrugated sheath will come. You go all the way from the duct to descending aorta. Always park in the descending aorta, the sheath. You will have total control. The moment you put only in MPA and middle of the ductus, you will have this problem. So if you put in descending aorta, always you can position the stent anyway while withdrawing the thing. And I saw Professor Dietmar-Shah, as Dr. Dalvi said, that self-expandable stent may be better in this situation rather than balloon expandable stents. I do agree with that point. Thank you, Nitin. Thank you very much.
Thank you, Nitin.
So we'll go on to the next presentation by Dr. Pankaj Sugoonkar. Dr. Pankaj is doing wonderful job in Pune and in Maharashtra, doing excellent cases. Dr. Pankaj is here to present one of his wonderful case of coronary fistula closure. Dr. Pankaj.
Thank you, Neeraj, for kind words. It's a very good evening to all of you, my respected seniors and colleagues, and very thankful to Satya and Ushri. Today I'm going to present the two cases for this, the coronary fistula closure. Am I audible at this point of time?
Yeah, Pankaj, you're audible and we can see your slides.
Okay, no problem. So my first case is basically 17-year-old girl is weighing approximately 35 kilos, saturation about 98%. She has a continuous murmur on examination, and on echo, I found it's a large coronary fistula from left main coronary artery draining into the RV. And there is a dilatation of left atrium and left ventricle. The plan in this case was a device closure of fistula. On the plate echocardiography, you can see the LA and LV are enlarged. On echocardiography, sometimes it is very difficult to see the course of the fistula because the views are quite a different one, because we cannot see a whole amount of fistula from origin to exit in a one view. So it appears in this view it is draining into the RV. So in the AP view, you can able to show that there is a very large size fistula which is draining into the RV because some PA is also getting filled from this fistula. This is RA view where just wanted to highlight more about the fistula, its closure. At this point of time, this is the location, this is the location where I found the fistula is very narrowest in size. So what I decided to take a snare and snaring out the wire in this fistula. So we cross the fistula, going into the RV into the PA, and then we snared out with the 6 French MPA one with the snare.
Pankaj?
Yes, sir.
Can we ask others that how do they approach this kind of fistula? I think
yes, sir,
there are quite a good number of people. They
yes,
can
sir.
give their suggestions.
Yes, sir. No issue, sir.
Sir, is it okay, or shall we just ask him to present it?
Either ways, I think you are free to moderate the way you want. I think it's perfectly all right. It's in your jurisdiction.
Because looking at the angiogram, we all having our own views and ideas. I know you are forming the AV loop from the femoral approach. All those things are quite visible and well appreciated. So let us take one or two panelist questions. Chetan, would you like to give a comment before Pankaj goes to?
I think there are two ways in which you can approach it. Basically, you may not need to create the AV loop if you can get into the.
Can you please go back to your angiogram, diagnostic angiogram, Pankaj?
Okay, sir.
Because on the right side, the mouth looks quite big actually. So you could approach it from the right side as well.
Neeraj?
Definitely distal constriction. So I would actually try to maybe make a AV loop and then try to cross it from the venous side.
You want me to tell, sir, what I feel?
Yeah, sure. Go ahead.
See, I feel that the angiogram, please run the angiogram. The angiogram exit point is below the tricuspid valve. When you have below the tricuspid valve, this is very difficult to go from the antegrade method, either from jugular or from the femoral. Exactly. My success rate in this case, if you go from jugular or femoral, is going to be catastrophic. They will develop hypertension.
Yes.
I will go from trans-aortic route and close it. That is my approach to tell you. But I would like to see your case.
Yes, sir. Shall I go ahead, sir?
Bharat sir would like to give comment.
I would like to make only one comment.
Okay, sir.
I quite agree with you, Nageshwar, that it is difficult to get these wires snared when they open just underneath the tricuspid valve. But based only on this angiogram, to complete the procedure retrogradely may be not that easy. So if I have that in my mind, I would definitely have a CT angiogram done prior to going into the cath lab so as to know where the tributaries are, where is the last tributary coming. I would not approach this retrogradely without having any further information, or do a Berman catheter angiogram into the aorta to find out how it probably opacifies the proximal coronary artery.
Sure. Okay. Varakan is there. Is Varakan microphone is on? Can you put on your video, Varakan? Varakan has got good experience in coronary AV fistula.
Hi, Nageshwar.
Yeah. Did you see
yes,
the angiogram?
Yeah, I saw it. Very interesting. And you know, one thing I haven't seen is a native coronary artery. So I'm not quite sure because of the image I see is not very clear, or because it's not clear because the flow is too much to the fistula. So I totally agree with Bharat that if I could not see the native coronary artery, I will not try to do it. So that's the thing I will do first thing. Secondly, you know, having an AV loop to me may be useful, because if I can put the catheter retrogradely from the venous side and then just block it, you know, by the balloon tip catheter whatsoever, and do proper angio, that'll be giving more idea for me how to tackle this. But totally agree that you know, you can close either antegrade very successfully, or I may try retrograde as well. So that's my plan. First, do angio properly to see the native coronary artery. Secondly, decide what to do.
Sure, Pankaj, you show us what you have done so far.
Okay, so basically what I seen on the angio is that the fistula after the origin from the coronary artery, it has taken a completely different course. So it is not very close to the coronary this thing. So after making out the AV loop, we were here after making out the AV loop. After doing the AV loop, what I able to see was that was a S-shaped curve which was is formed inside from R8 to RV in such a acute angulation from this. So initially I was also decided to go for the antegrade, but because looking at this angle angulation, I canceled my antegrade plan. I said the retrograde appears to be better for me. So this was the area, this is the area where my narrowest size of the fistula is there. This border I kept in mind while doing the intervention, deploying the rewiring. So because sometimes when we go retrogradely, we can do a hand angio, but the size of this fistula was approximately 12 to 14 millimeter, and the narrowest size was approximately 6 to 8 millimeter in 2 or 3 different circumstances. What I had done in this case is what I have taken, I have passed the catheter retrogradely. Just what we do, sometimes we take the sheath and just force the retrogradely. Before that, if you want to test the patency of that fistula, whether the sheath will go or not to go, sometimes it is better to push the catheter plus how it easily goes. So you will get the idea how it will cause a difficulty in putting the sheaths. So initially I have put the catheter across the narrowest portion and taken it. It appears to be good. So I had taken a 8 French Moulin sheath across it. So here, the narrowest point, I know that this is a spinal border, the narrowest point of here. So my aim was to cross this narrowest point and keeping the loop in situ. So I have gone as much as distally and crossed the narrowest point here with the Moulin sheath. And here I have taken a 22 millimeter Apr22 Apr22 vascular plug 2, which is 16 millimeter in length, 16 to 18 millimeter in length. And here I wanted to deploy at the narrowest point, but once it has start deploying, the angulation has formed in such a way, sometimes it's very difficult to retrieve back. But I said, because I was in the very safest location, I just deployed from the narrowest point, distal to the narrowest point, and deployed the whole, the 3 dumbbells of the Apr22 can nicely seen is deployed across the things. So here I have taken the angio. My narrowest point was here. This is the spinal border. Because that, as I said, when you go retrogradely, if I want to take an angio with such a large vascular plug, sometimes it is very difficult to localize which is the narrowest border, narrowest size of the fistula. So these borders are spinal borders are very helpful. Like we do in a PDA cases, we assume the tracheal border. In such a cases, the spinal borders are also so sometimes gives a very good idea. So I had deployed the whole largest 22 millimeter vascular plug here. And we release it complete. After the release, you can see the plug has taken up shape. Sometimes I feel it is a little bit oversized because the length of the, it does not get a space to open the distal disc here, proximal disc here. But after that, I have taken the angio here. The angio here, it appears to be good. It has covered the most of the exit. It has covered all the path of the fistula, as well as it has covered the shortest size of the fistula. And it appears to be good for me. And it is away from the any native coronary artery as well. So I have decided to keep it as this. And this is the final picture after deploying the Amplazar vascular plug to 22 millimeter across the fistula.
Pankaj,
yes, sir.
I will just give a comment. Then I think seniors are waiting. See, fundamentally, I would agree with Bharat sir. Now, at this point of time, we should have definitive coronary anatomy before we close the fistula. We should have done a balloon occlusion angio. You have a very good AV loop. You should have taken a balloon and another catheter, demonstrated all the way in multiple views to show the coronary artery. Because whatever coronary artery you are showing, it did not show complete coronary artery. It's only a branch which is shown. And we don't have knowledge about what is the distal size of the segment, whether 22 millimeter appears very big. That's where the disc is not fully formed. These are my comments, but not necessarily you should agree. I will leave this discussion to seniors and Varakan, Chetan, everybody are there.
Okay, my plan in this case was like the size of the fistula is approximately 12 millimeter and the narrow segment was approximately 8 to 10 millimeter. So in most of the fistula, we go 1.5 times to 2 times of the size. And so in this case, I had chosen this 22 millimeter, which was the largest size available for me, because I have chosen the largest size as such a large size because if we choose the large size of the AVP2, we can close the fistula as well at the narrowest point, as well as the side pressure of this device also can cause the closure of the fistula itself. So these two things was in my background. So that I had chosen this Amplazar vascular plug to such a large size.
How was the echo after deployment about the inflow and the
so it is quite away from the inflows and the outflow, because I have not inside the RV. I was not inside the RV. I was not inside. I was just to the RV exit. Okay, I was not in the RV itself. I was just in at the RV exit only. So I had not crossed the RV itself. So I just.
Pankaj, I can't believe that your distal disc is not in the RV. It cannot open so well unless it is in the RV. It has to be in the RV inflow. I would like to see that echo.
Okay.
Second comment I wanted to make, what you are seeing is only the OM1 branch of the circumflex. We don't know whether there is OM2, OM3, which is already closed. And important is also to make a right coronary angiogram to know when you have a circumflex fistula, whether it is a circumflex dominance or the right coronary dominance. Because if it is a circumflex dominance and if you close the fistula the way you have closed, you might compromise important circulation like PD or something, which may not be evident immediately because there may be some collaterals or something like that. But as a matter of principle, what you have done is great job. But as a matter of principle, the deployment of the device has to be decided after you delineate all the branches. If you feel that there are branches distally, you must delineate them. If you don't want to form a loop and send a balloon occlusion from the venous side, send a balloon from the arterial side, take another arterial puncture and make an angiogram so as to show where the arteries are. Otherwise, sometimes you may end up with a delayed infarct or some such thing.
Okay, okay.
Who is near asymptomatic.
Okay. Okay, okay.
My question to you is, what was your anticoagulation protocol after you closed this? Did you send this patient home only on antiplatelets or you used coumadin also?
No, I initially for 2 days we were given a heparin continuous infusion where we monitor the APTT in this case. Initially, we maintained the heparin between 60 to 80, and after that I discharged the patient on the only the aspirin in this case.
Pankaj, are there any ECG changes? Or,
Definitely. What we had done in this case is we continuously 6-hourly regular intervals ECG for 2 days. So our protocol is to do ECG monitoring every 6-hourly in this case, and there was not a single change in ECG neither from the before or in the post-op. So after 2 days, we continued discontinued the heparin and discharged the patient on the aspirin. On follow-up, she has now we did this case in the month of December, and after that also there was no problem in this case. She's continually doing well.
Yeah, Chetan has got a question.
I think basically we don't do that many coronary fistulas, but whatever little we've done, and I think whatever listening to various experts who do a lot of coronary fistula, people like Vorakkan and Praful Kelkar, shouldn't there be a reason to close the entry point here as well? Because now you've got just a blind sac, which is going to start developing some clot in it, and there is a theory about clot propagation. And is antiplatelets good enough in those situations?
Well, may I share idea? This is very challenging, interesting case. We deployed the device already, so I think there's no point of discussing about the device at the moment. But the point I would like to say would be, if I were the person who in charge on this patient, I may continue at least warfarin for 6 months, and then I probably will repeat either a CT angio or the selective coronary angio in order to see whether how the clot is propagating, and then I will decide again whether should I continue as the warfarin, or just switch to the aspirin. So that's my plan. And I'm so happy that when you say that the patient now is doing well, because it means that it should be fine at the moment for the patient.
Yes, this is the case in the month of December, and definitely the 4 month has left. What we had decided this case to do a cardiac CT scan after 3 months, but because of all this corona issues is going on, we could not able to do the CT scan right now. But once it is over, then definitely I plan to do a cardiac CT scan in this case.
Lovely, sir.
But is it a standard practice? Are people only closing the exit point? Is there no pursuing of trying to close the entry point as well?
Chetan, I think the coronary branches are very close now. So he put the device AVP2 from very distal to almost to mid segment.
Yes.
The approach of closure transarterial is well appreciated, Pankaj. There is no question about that. I do agree with Bharat sir, as a matter of protocol and all, it's a good idea to demonstrate. Since it's a teaching point, we are emphasizing. But your approach and you deployed it very nicely. There is no question about that.
Yes.
Nageswara, just to share with you just a bit about the Chetan question about closure of the entry point, exit point. So I have one patient actually. I try to close exit point, and proximally there's a big aneurysm, but unfortunately I didn't close the entry point from the beginning. So 5 years later, that aneurysm getting bigger and compress the right ventricle. So what I've learned, if we have aneurysm and there's a narrowing proximally, distally between the aneurysm, I will try my best to close either on the exit and also entry point from the beginning, if I could.
I have only one question to Vorakkan. If you close only entry point as proximal as possible, what will happen to the exit? It will anyway invalidate. We don't need to close them. Especially from our side, when you don't want to put many devices. Like last week, I saw our friend Tin put a couple of devices. So when you put very proximally, you need not put another device in the exit point. I would like to have comment from other panelists here.
Nageswara, if you remember, we did one case together during CSIAP 2017. Yes. So that's a case exactly the same as you mentioned. So we eventually decided to block only the entry point, and we leave the exit point like that. And that day, actually, some of the expert opinions, they said, well, you may have a clot inside the aneurysm, and then the clot may embolize to whatsoever. So some of them, they prefer to also block the exit point. So again, there's a pros and cons on that. But in general, if you go from the vein, get to the RV, to the fistula, and then if you can go a bit more proximal to block the entry point first, and then see how does it look, and then you have a chance to block the exit point as well. So that's the thing. I think that's a controversial thing. I would like to see learn from other opinions too.
None of this discussion, for the sake of juniors here, none of this discussion is evidence-based. All of us think that this may be good and that. So don't think that all of us are perfect. There may be some things which we also don't know. But I completely agree with Nageswara. When you close the entry point, I do not see any reason to close the exit point. Because even if there is a thrombus formed, if there is no flow across the entry point, where will that thrombus go? That thrombus cannot embolize anywhere. So if there is no flow, why should we be closing both entry and exit and spending additional 60 to 70,000 when resources are so limited? I don't think that I understand the logic. There may be a logic, but I don't understand
it. Is it, I have one very small question.
You can start sharing your screen.
Yes, okay.
So does that mean that everybody should go for just closure of proximal end and not the distal end at all?
I would do that. At least proximal, Chetan.
Yeah.
Distal, you may decide.
Can I ask about one question, because we are not very comfortable closing the proximal end of the fistula because it's very close to the coronaries. We are quite comfortable closing the exit and the narrowest point of the fistula. So I don't know whether the proximal, I have not seen it in the proximal closure of the fistula. I don't know what is.
May I share, reply this question first, Nageswara?
Yes.
Yeah, I think the key thing will be the branch, the distal branch. I think that the key is you try to avoid closing the branches as less as possible. So it means that if the proximal part, there's no branching distally, just go for proximal closure. But if there's branches coming all the way to the exit, then you have no choice. You just go for the distal closure.
Okay.
So we'll close this particular case. Neeraj, yeah, can you please introduce and then...
There is another one case of the fistula from the antegrade approach.
Okay.
So I quickly present this. This is a 7-year-old boy with a coronary fistula.
Sir, Pankaj sir, Prashant sir is sharing slides.
Satya can't share because he.
So, Pankaj, I think maybe we'll ask from the house because we are already 6:40.
Yes, like we've crossed the time. Like Prashant sir, can you?
So we had a wonder discussion on your case, and we could actually discuss both the things. So if we can go to the next case, whatever Dr. Nageswara feels or Dr. Dalvi.
I think Prashant can present first. If time permits, then probably Pankaj can show. Since Prashant is waiting. So Dr. Prasanth Patil is from Hyderabad. He's a pediatric cardiologist working for the past 15 years. Now he is working at a care hospital. We worked together for a short time before this event. Welcome, Prashant. Please present your case.
Thank you, sir, for your kind introduction, and good evening to all the teachers, masters, and my colleague. And thank Satya for such a nice webinar. I'm going to finish this case in very short because this is most of us might have been doing. This is a case of VSD device closure in mirror image dextrocardia. This was a 4-year-old child with a failure to thrive and recurrent LRTI with all the Pansystolic murmur, the heart sounds were better heard on the side. This was the X-ray with the cardiomegaly and situs inversus dextrocardia with USG abdomen also confirmed the same findings. The echo showed there was moderate to large perimembranous VSD around 7.6 millimeter on the LV side and 5.5 millimeter on the right ventricular side, with restricted by tricuspid valve aneurysm with grade 2 tricuspid valve regurgitation. As you can see, this is the situs inversus and IIS is intact. There is a slight LAL dilatations with tricuspid valve regurgitation. This was the VSD, which we measured in parasternally, which was away from the aortic wall. There was some tricuspid valve regurgitation, and it was measuring around 7 millimeters. So we took the patient on table under short GA. This was the angiogram. The on angio it was measuring somewhere around 6 millimeters. So we crossed the VSD.
You can't sit here. So you can.
We crossed the VSD retrogradely and snared the wire from the LSVC. We formed the AV loop and we deployed 10-8 Amplazer ADO1 device. So this was the final result. So post-operative, angio, there was a small residual VSD grade 2 tricuspid valve regurgitation. As you can see, this is the immediate post-op echo. There was some regurgitation, which subsided after 3 months. This is a echo of the same patient after 3 months with, there is no residual VSD, no tricuspid valve regurgitation, and patient was doing fine. So this was the post-op echo, post-op X-ray. This was the post-op ECG, which showed normal sinus rhythm. So thank you, the panelists, for giving me the opportunity to present this case. If any questions are there.
Thank you, Prasanth. It's a very good case in a mirror image situs inversus totalis with dextrocardia. I think technically it is just opposite what we are doing in a VSD in a situs solitus location. What is the QPQS in this patient? Because you said moderate pH, that's the reason.
Yeah, it was 2.7:1. 2.7.
Bharat sir is smiling.
No, I'm smiling because, why I have stopped doing VSDs, perimembranous VSDs. One of the reasons is a case very similar to this. This child came to me at around 16 months of age. Mirror image dextrocardia, moderate sized perimembranous VSD, not growing due to respiratory tract infections. Identical case. Mild to moderate tricuspid regurgitation. Excellent fit with ADO1 8/6 instead of 10/8 because the child was smaller. No residual shunt, trivial tricuspid regurgitation. Gained tremendous weight. First follow-up 6 months, no problems. Second follow-up 1 year, no problems. Third follow-up at 1.5 years, incomplete left bundle branch block. Fourth follow-up with florid respiratory tract infection, breathlessness, complete left bundle branch block with ejection fraction of 15%. So this dyssynchrony with dilated cardiomyopathy was the last nail in the coffin for me to stop doing perimembranous VSDs. Because I just could not take it. That a VSD closure can cause cardiomyopathy, and I'm told that there are cases like this even in surgical literature. But I could not take. The only reason, I'm not saying what you have done is wrong. You have done a perfect thing. But just because it is 3 months or 6 months, don't leave the follow-up. Follow-up has to be eternal.
Yeah.
So, I don't know that L loop of the ventricles with mirror image dextrocardia does something to the left bundle. I have no idea. But keep a watch on this and keep a watch on this synchrony, for God's sake.
This case was done 1 year back and child is doing fine. Now, till now, there are no ECG changes.
Yeah, so it is just my advice to keep a watch on the left bundle and how the child behaves.
Maybe, you know, we did not have the availability of Coronary MF at that time. So otherwise we would have Coronary MF instead of ADO.
I think this particular case, I do agree. ADO1 is probably ideal because you have already tricuspid regurgitation.
Yes.
So it is subsided. So ADO1 is not a bad option here.
It's a good device, but it was only that case that I have seen. And when I saw it, very few people in the world had seen LBBB with ADO1 causing dyssynchrony and dilated cardiomyopathy.
The only problem with ADO1, you have to oversize it. You cannot put exact same size. You have to oversize at least 1 to 2 millimeter.
Yeah,
whereas Coronary MF, it is a double disc device and a medium profile, medium to low profile. So the tendency we presume, but the time only will tell, like as Dr. Dalvi said, time only will tell. So the risk of conduction system we claim is a little bit lesser.
Complete heart block, Nageswara, you can do something. In a complete heart block, you can put a pacemaker if the patient comes to the hospital. Or but in a LBBV with dyssynchrony and dilated cardiomyopathy, I'm just twiddling my thumb unless you do a biventricular pacing or a His bundle pacing or some such thing. And the baby is too small for that. Now she's 6.5 years, but still with an ejection fraction of 20%.
Yeah. We do a lot of VSTs, as you know that.
Yeah, of course.
So
and the whole country does it, and I have no issues with it.
Yeah.
I wanted to caution.
I'm going to take your point that this is not that we are going to stop the follow-up. We need to see that.
Correct.
We'll
That's the only point I'm trying to make.
Dr. Varakan. Your microphone is off. Yeah.
Yes, Nageswara.
Yeah. So the question, did you get chance to see the presentation by Prasanth?
Yeah, I did.
Okay.
Well, did you ask me about the LBBB things,
you can
right?
give a comment. Your comment is very.
Well, only one case I did for dextrocardia. That time I did with my friend from Vietnam, actually, and that was very challenging because it's kind of the other way around of thinking and doing things. So in terms of the angiogram, I mean the angle, the view, it's just opposite to what we had. So as Nageswara mentioned in previously, I think we just do the same thing but in different ways. And for Bharat comment about the LBBB, luckily at the moment so far I don't have this. But again, I keep in mind every time that I talk to Bharat, and that's very important thing that we need to follow up the patient as long as possible. But one thing I've learned also from CSI last year, I went there and then listened to a talk from Indian doctors. I can't remember the name, but what very important message to me is if the patient has it, even if it's a year or more than a year after implantation, try to take it out. That may help. So that's what I've learned.
Yeah, as a matter of fact, Jai Ranganath presented that he took it out after 1 year and then it got okay.
So it's a very good presentation. If there are no questions, probably we can wind up this session. Are there any questions, Chetan? Would you like to give a comment or that's fine? Okay. Neeraj?
Asked in the forum, what about antegrade approach in particular case which Prasanth presented? Cross from the RV side and then sheath.
In a case of dextrocardia, it is very difficult. I found. I thought it is better to cross retrogradely rather than antegradely. Maybe it would have been a situs.
We have quite a good experience of dextrocardia and situs inversus together. We have done around 6 to 7 cases. totalis. But as Varakan, everybody knows that just need to do opposite sides of what it's only our mind we need to invert it. That's all. There's nothing technically demanding in this particular subject.
I wanted to make one announcement before we stop. Is
Okay.
that tomorrow's session will begin at 6:30 p.m. and not at 4:30 p.m. because of the timing issues. So to everyone, tomorrow's session on pulmonary valve is at 6:30 p.m.
Okay.
You can go ahead, Nageshwar, with your concluding.
No, that's a very good. Actually, I thank Chetan, Dr. Aliva Stamper, and our special guest always Varakan, Bharat sir, Neeraj, and all the presenters. They put lot of efforts to present their cases. I think it's a very good, wonderful discussion. At the end of the day, we should not feel bad that we are commenting the cases. It's all matter of learning point. As Dr. Baradali said that nobody is perfect. We are only presuming and taking a hypothetical situation that we may be correct, we may not be correct. Still, we don't have answers, especially like a coronary AV fistula, whether to give lifelong oral anticoagulants or antiplatelets or dual, single, all these things only time should answer, and we should have collective efforts to share our knowledge. With this conclusion, I would like to end and say good night and thank you very much.
Thank you.
Thanks.
Thank you, sir.
Thank you so much, sir. Can I end the meeting, sir?
Please, go ahead.
Thank you, sir.